So first, I want all the panel members to introduce themselves and then say some key areas they are working, which is related to lobular breast cancer. So let's start with Dr. Vassal.
Sure, my name is Andrew Vassal. I'm from Radiation Oncology here at the Cleveland Clinic. The majority of what I do is treatment for breast cancer, and certainly lobular carcinoma is something we're always thinking about in radiation oncology. Large part of what we're always thinking about is dose of radiation, fields of radiation, majority of... Oh, can you hear me now?
Okay, so I'm sure our audio team will fix that.
How about now? Is that better? Okay. My name's Andrew. I'm a radiation oncologist here at the Cleveland Clinic. So ILC definitely is something we have to think about when it comes to radiation oncology. We work very closely with the whole group in radiology and breast surgery and medical oncology to figure out what's best for each individual. But due to the invasive nature of lobular carcinoma, most patients that have lumpectomies are being treated with whole breast radiation. But there's a trend now in our field to do smaller areas of radiation to minimize side effects. But that is the kind of trend that we're moving toward, is to try and minimize the dose of radiation, minimize the area getting radiated, but always trying to make sure that we're being safe in doing so.
Okay. So we'll, I think moving forward, we'll speak up, and I'm sure that will fix. Yeah. Dr. Cruz, yeah.
I'm Megan Cruz. Can you hear me okay? I'm a medical oncologist here at Cleveland Clinic. I see only breast cancer patients. And my involvement in the lobular breast cancer
Can you hear Dr. Cruz?
space
You can. Okay.
really came out of my patient experiences. As a junior faculty, I was really struck by some of the emotional challenges and the ups and downs that my patients face each day with this diagnosis, and it really left a lasting impact on me. So I'm working with some of our other panel members on kind of answering a lot of the basic questions we take for granted in the breast cancer space, making sure we have those answers for lobular breast cancer. I think you'll hear more about that. And also I'm very interested in optimizing preoperative or neoadjuvant strategies of treatment for patients with lobular breast cancer.
So Dr. Erin already introduced me. Bill Gradisher from Northwestern. I'm a medical oncologist and I focus only in breast cancer. I also chair the NCCN panel that helps develop the guidelines, and Dr. Abraham's a part of that as well, for treating breast cancer. And like many of the other people on the dais up today, we have an interest in precision medicine and trying to learn more than simply, not to say anything negative about pathologists, but not just looking through the microscope. We try to understand on a molecular level, and hopefully as we go forward, we're going to be able to tease out certain characteristics, not only of lobular, but other cancers as well, and tailor therapies accordingly. And the net outcome, hopefully, is a better treatment and better outcome for patients with lobular cancer, which is the subject of tonight's discussion.
Lee, if you could introduce LBCA and say a little bit about how you started. And
Thank you. So my name is Lee Pate, and I was diagnosed with lobular breast cancer in 2011, stage 2B. And at that time, I remember going on, first of all, I was diagnosed and I picked my head up out of my hands after I got the phone call, and I, of course, went to Dr. Google first and foremost. And I was like, what did she say I had? And I typed in globular breast cancer. And Google says, do you mean lobular? And I was like, okay, so we're starting from scratch here. And I started to do some research, and very quickly just found that there wasn't very much information out there about lobular. And when I started to look for research through PubMed and things, a lot of those studies were very old. And it was treated, I quickly learned it was treated with the same standard of care. So I went through my treatment, and then in 2016, there was a first annual lobular breast cancer symposium hosted in Pittsburgh, and 30 advocates around the country flew in to be a part of this, and we were just so thrilled because for the first time there was something for us as patients that specifically addressed our disease. And we left there energized, and a group of us stayed in touch, and we kept working together, and we worked with Steffi And we formed the Lobular Breast Cancer Alliance out of the group of advocates that came to that very first symposium. And it's ever since, we've all been a little shocked and surprised at how much it's actually grown. And we have a website, lobularbreastcancer.org. If you haven't found it, we hope you'll find it, and hope you'll get on there and check out the information there and learn to be involved. Our goal is to work to advance research for lobular breast cancer and to educate about the disease and really raise the profile of lobular breast cancer in the breast cancer world. Thank you.
Thank you for your work. Is the microphone working better now, or you can hear better? Okay, thank you. Right. Okay, Dr. Astrid.
Good evening, everybody. Can you hear me? My name is Steffi Österreich. I'm a basic and translational breast cancer researcher, so I do not treat patients. I'm not a physician. My research interest is hormone response, so endocrine treatment response in patients with breast cancer. And I am at the UPMC Hillman Cancer Center in Pittsburgh. When we looked at estrogen receptor and endocrine treatment response in breast cancer approximately 10 years ago, we suddenly realized that response to some of these hormonal therapies seems to be somewhat different in lobular than in ductal breast cancer. And when I then went on to PubMed, which is basically an online database for published literature, I realized, wow, there was amazingly limited literature on hormone response in lobular cancer. And at that point in time, my group decided to really study this. So this was 10 years ago. I am now co-directing a research lab with Dr. Adrian Lee, and we really he is very interested in genomics and precision medicine. I'm very interested in biology, estrogen receptor activity, models to study lobular breast cancer, and we work with clinicians, we work with patient advocates, and we really have a passion to figure out what's unique in lobular breast cancer, how can we target it, are there really specific pathways which we can target to improve therapy for patients with breast cancer. And I count myself fortunate that we have lots of great national and international collaborations, and also working with patient advocates, Lori, Lee, many others in the audience from LBCA, Susie. And I'm happy to be here and to discuss this tonight.
Thank you.
Hi, my name's Erin Kelly. Can you all hear me? I'm a breast pathologist here at Cleveland Clinic, and my interest in lobular carcinoma is really in some of the in situ diseases, so the diseases that kind of are non-obligate precursor lesions, so they don't always necessarily turn into an invasive carcinoma, but there is a risk. And there are some variants. We think of things that are truly classic lobular carcinoma in situ, and we can recognize them under the microscope and know what they look like, but then there are some variants that look quite different, and really trying to figure out what their behavior is. And we know on a molecular level some of these lesions are somewhat different than what we think of as classic lobular carcinoma in situ. And that's the beauty of being at a place like Cleveland Clinic, is there are a lot of unfortunately there are a lot of patients, but that also means there are opportunities to look at some of these lesions that really don't have a good kind of standard of treatment. So that's kind of from the pathology side what my interest in lobular is.
Good evening, I'm Laura Dean. I'm one of the breast radiologists here at the Cleveland Clinic. Part of being a breast radiologist, a big part of what we do is screening for breast cancer, all breast cancer, but also specifically for invasive lobular carcinoma of the breast. So a lot of what we do, screening and diagnostics, really specifically pertaining to invasive lobular cancer is, and we'll hear more about this evening as it pertains to challenges with imaging, but because of the very subtle ways in which invasive lobular cancers can present in the breast on mammography, we'll hear about that from a pathological standpoint as well, but there are certainly challenges for us as the radiologists. So one of the things that we've been doing at the Cleveland Clinic and that we've really been looking at throughout the radiology literature is what type of extra screening can we do, what in terms of an imaging approach to these patients may be helpful to help us identify these very subtle cases early. We'll talk a little bit more about this, but supplemental things like tomosynthesis or the 3D mammogram, which has really been rolled out throughout the Cleveland Clinic system, has been much more common in the past couple of years and is becoming more standard of care across the country. Other supplemental tools such as ultrasound and MRI, which are very helpful. Some of them are still investigational, but certainly people are looking into what can we do in imaging to help find these cancers early.
Hi, I'm Stephanie Valente. I'm a breast surgeon here at the Cleveland Clinic. My role in lobular cancer is a lot of times the surgeon is the first person that a patient sees once they get the diagnosis of cancer. And so my job is to talk to the radiologist and the pathologist and then help explain the diagnosis to the patient. So I take time and say, this is what you have. This is how big it appears to be, and looking at mammogram, ultrasound, MRI. Does it look like it's in your lymph node? Does it look like it's in more than one spot? Anything in the other breast? And so help the patients understand exactly the stage of their disease, and then help determine whether or not surgery first is the right option, whether they need systemic therapy. And so it's an honor to help work with a patient and their family and say, what do we need to do next? And a lot of it, is saying, this is large, we might have to remove your whole breast. This is small, you have options. And then working with plastic surgery, if we need, to help remove the cancer, get clear margins, take care of the lymph nodes, and leave the patient with a pleasing cosmetic result.
Hello, my name is Schwarz. I'm one of the reconstructive plastic surgeons at the Cleveland Clinic. And my role in working with patients who have lobular carcinoma is to really work closely and collaboratively with our breast surgical oncologists. A number of different options such that we can restore their both form and function of their breast after surgery. Another interest, and I think it's something that is unique to what we do here, is we've kind of taken a focus on trying to mitigate against some of the challenges that occur when folks need their lymph nodes removed or have some ancillary treatments like radiation or things that predispose patients to lymphedema in later stage lobular cancers. So we've devised some strategies to try to preserve and reconstruct the lymphatic system. And then in folks who have had more aggressive treatments and have developed lymphedema, there are some things that we can provide to perhaps improve their quality of life and maybe decrease the severity of the condition.
So as you can see, the questions are kind of coming up to the top based upon the lights. So we can start with the first question. Lobular cancer is known as a sneaky cancer. What's the most reliable and valid diagnostic method? So probably we can start with the radiology and pathology.
Sure. So starting from where most of us start, which is with a screening mammogram, assuming the patient doesn't have a palpable area that they're worried about in their breast tissue, we know that screening mammography is still really the gold standard for screening for all different types of breast cancer. So invasive ductal and invasive lobular cancers and others, but breast cancer in general. So we have decades of evidence and thousands of patients showing us that screening mammography does save lives. Now we also know that screening mammography is not a perfect test. It is a very good test. It does have a good sensitivity in a lot of patients, but we know, and we're hearing more about the lower sensitivity of mammography in some certain patients of subsets. We hear a lot in the news about dense breast tissue and how that poses a definite challenge in screening mammography, especially for younger or premenopausal women. And so there's been a lot of interest in what can be done to increase the detection of cancers, especially in women with dense tissue. So what has really helped to revolutionize screening mammography, especially in more challenging cases like a very subtle developing invasive lobular cancer, for example, or detection for someone with dense tissue in general, is tomosynthesis. I kind of alluded to that a little bit in my introduction, but 3D mammography has really revolutionized the way we as radiologists are able to approach a screening mammogram. We're still just kind of talking about the screening population. But those patients where we really now are able to scroll through that tissue, whether it's dense tissue or fatty tissue, tomosynthesis or the 3D mammography has really shown to be beneficial across all different breast densities. So that's one tool that is really revolutionized as part of a screening tool. Now, in terms of addressing the sneaky nature of invasive lobular cancers, from a radiologist standpoint, what that means for me is, whereas in the more common invasive ductal cancers will often present as a spiculated mass or a dense area of architectural distortion or pulling inside the tissue, many of those invasive ductal cancers have calcium deposits, which are easy to see on mammography. Invasive lobular cancers, on the contrary, can be a very subtle change. So something that I look for is anything that is developing. So these can be very subtle sort of developing areas on the mammogram. They can be new sort of subtle, not necessarily a mass, but it can really look like the rest of the breast tissue in that patient's breast. And so as the radiologist, we really have to have a very high level of suspicion for those. That being said, mammography is still the gold standard, and in patients who are at average risk of breast cancer, mammography and then adding tomosynthesis to that is still what is recommended for screening.
This is an image of what normal breast looks like. This is just kind of a baseline so you can see changes. This is really the area where carcinoma develops. This is a terminal duct, and these are lobules, and these cells here that line this are typically the cells that develop into either a lobular carcinoma in situ or a ductal carcinoma in situ, and then can eventually potentially go on to invade the stroma and become an invasive carcinoma. So it's important for us to be able to tell the difference between something that's a lobular carcinoma in situ and something that's a ductal carcinoma in situ, mainly because Dr. Vassal might potentially treat these very differently. This patient has a partial mastectomy and it's a lobular carcinoma in situ. He's not going to offer her radiation, whereas if it's a ductal carcinoma in situ and it's a partial mastectomy or a breast-conserving surgery, that patient will likely be offered some sort of radiation therapy. So our challenge is in deciding if this proliferation, this is that same kind of lobular area and ductal area I showed you originally, now it's really expanded by all of these cells. And it's this solid proliferation. And when I look at this, I think this is either a solid ductal carcinoma in situ or this is a lobular carcinoma in situ. So I want to be able to tell the difference, and something that we can use in the laboratory to help us is an immunohistochemical stain called an E-cadherin. So we know that lobular cancers lose expression of E-cadherin. And E-cadherin is this cell-to-cell adhesion molecule. So the cells want to basically adhere together if E-cadherin is present on their membrane. So if we look at a ductal lesion like this, all of this brown staining is actually E-cadherin that's around that cell. Whereas if we look at a lobular lesion, there's no expression of E-cadherin. So this helps us tell the difference between something that's a lobular carcinoma in situ or a ductal carcinoma in situ. This lesion has a bit of both. There's an area here that is kind of, the cells look like they're falling apart, and that's because they have loss of expression of E-cadherin, where this swath of cells here like each other and they're clustering up to each other. And if we do an E-cadherin on that, you can see that this entire area here is expressing E-cadherin, and that's a ductal component in this otherwise lobular lesion. Now, as far as what Dr. Dean was talking about in relation to ductal cancers forming a lesion. This is just a low-power view of an invasive ductal carcinoma so that you can see the difference and why these things can be so sneaky. So this is a ductal cancer, and it's forming this well-rounded lesion that we can make out. She can see that on imaging. We can see that when we look at this tissue grossly, and that's what we see under the microscope. And that's because these cells really cluster up together and are cohesive. You compare that to an invasive lobular cancer where we have these individual single cells that are basically streaming through the fat, and they are doing this kind of single file infiltration in the stroma. So they don't form a very discrete mass at all, and they're very bland. So if we were to look at this and not have good history from the radiologists that they are very concerned about this, we have to put it all together, because this could be something that would actually be easily overlooked as just inflammation in the fat. So it's important to correlate everything together between the radiologist and what they're seeing, whether it's an architectural distortion. It's important for us as pathologists to always have this in the back of our mind, that we don't want to miss the potential of a lobular cancer. And that's just a high-power view of these very kind of bland, nondescript cells, and that's very classic for an invasive lobular carcinoma.
Good, thank you. So then let's go to the second question in the list. That's from Lisa. Said, is it inevitable that lobular cancer metastasize even for stage 1 or stage 2? Dr. Gradisher or Dr. Cruz? Or
I can start. So I would say no, of course not. We think that even if we weren't talking about lobular carcinoma, a lot of what prognosis is based on is what we think of as volume of disease. So that is sort of a crude clinical measure of how much you see either in the breast or the nodal involvement. And we would tell most patients that have stage 1 disease, regardless of their underlying, what it looks like under the microscope, that most of those patients are cured by the surgery alone, even before we get to anything that we might do as medical oncologists. So that's both reassuring and very unsettling, because it implies that there are a fraction of patients, despite that statement, that will have a recurrence of their disease. And it sometimes becomes difficult based on clinical parameters to know who they are. So as the amount of disease goes up, our concern about microscopic disease somewhere also goes up, and we are more inclined to offer adjuvant therapies, either in the form of chemotherapy or anti-hormonal therapy or other targeted therapies, depending on the molecular characteristics. But we also have certain tools that we can now use, and I don't know, Megan, you may want to comment on that.
Sure. So I wanted to bring one thing forth in our conversation today, which is a test that's under development from a research group in Australia. And I have to admit that this test was brought to my attention by one of our dear advocates, Susan, who you all got introduced to earlier. But it's a test that's known as LobSig, so LOBSIG. And as the name implies, the idea is to try to find a special signature that would apply to lobular cancers in the same way we think about these tests that you hear about all the time, whether it's MammaPrint or Oncotype, giving us a signature of behavior for maybe the more typical ductal carcinoma. So this test it takes into account not only gene expression like tests like Oncotype and MammaPrint do, but also some gene copy number variations. So distinguishes hopefully some of the biology that makes invasive lobular cancer different than invasive ductal carcinoma. I will say that this is early in its development. It's the first paper we have, so it's just being studied and it's kind of in its discovery phase. So we hope that it will be able to be validated or proven to be useful in other large sets of lobular patients. But in this initial publication, there was a suggestion that it helps to differentiate those lower risk lobular cancers from the higher risk, or those that are more likely to metastasize. And I think that is what we're all looking for, is the ability to sit with our patients early on and say, either we feel really good about this cancer, maybe we do not have to be as aggressive about your treatment in certain ways, or we still can be, but at least we're optimistic. But more importantly, find those that we're worried will have recurrence later on and be as aggressive as we can up front. So I encourage you all to take a look at that if you haven't seen it yet, but it's something that we're excited about in terms of tailoring therapy, as Dr. Gradishar pointed out earlier.
But you won't be asking your doctor for that test.
Right.
It's part of an investigational approach.
So I want to add one more question to that early stage, and I was going through some of the questions. So the question was, can we still do lumpectomy in early stage lobular breast cancer? Dr. Valente and Dr. Vassily, if you could answer that.
Sure. From a surgical standpoint, the options for lumpectomy versus mastectomy are based on extent of disease. So if you have a breast and a small cancer that would allow you to have a lumpectomy, doesn't look like there's anything else in the breast, then if we're able to do the surgery, remove the cancer with clear margins, understanding that radiation helps prevent it from coming back, then I think that is a good option. Some people think that if they remove both breasts and their left arm, it makes them live one day longer. And it's an anxiety thing. You say, oh my gosh, get this out tomorrow. But I think if we take a step back and just say, in your case, it looks like it's just one area, and just removing that area at this point in time should be good enough. Andrew, do you want to comment on radiation?
Sure. You know, the radiation, it really kind of dovetails to what the surgeons do. And our job really is to help that patient really achieve what they're looking for, which usually is to reduce the chance of recurrence. And so radiation does come in many different styles, and we're always looking to see, what is the patient's interest, what are some of the logistics for the patient, medical conditions the patient might have, the ability to tolerate radiation. But most patients who are going to have lumpectomy are encouraged to have adjuvant radiation therapy to help prevent recurrences. And then the field size of radiation in general, we're doing mostly whole breast radiation, but for patients with small tumors that are favorable biology overall, with good margins, well-imaged patients as well, there's a trend now toward doing smaller radiation fields to help minimize toxicity.
So I'm going to combine the next two questions. If lobular cancer metastasize, is it hard to detect in other locations? I'm sure Dr. Dean can answer that. And then the next question is unique biology, and hopefully Dr. Ostrich can expand on that. So Laura, you can start.
Sure. So lobular breast cancer, like ductal breast cancer, can metastasize to common places like the liver and the lungs. But what we know about invasive lobular cancers is that they also sometimes like to metastasize to more unusual locations, and they can be very subtle and sneaky also in the ways they metastasize. So this is very helpful for the reading radiologist to know if it's a pathology of an invasive lobular cancer. That means they're going to look much more closely at more sneaky locations like the lining of the abdomen or the peritoneum. Invasive lobular cancers can go to the GI tract, so they can really be very subtle kind of soft tissue deposits that develop along the GI tract. They can go to the lining of the lung. They can even go to the lacrimal ducts outside the eye. So these are locations that are not classic for breast cancer, but it is certainly helpful for the radiologist to know. And the question, can they be sneaky? Absolutely, they can be. Metastatic disease of any kind, not just invasive lobular carcinoma, can be very difficult to detect. So, and we may talk, I'm sure, as some of the other questions come up, but the modalities that are most commonly used, so you can use either a bone scan to look for any evidence of bony metastatic disease in combination with a CAT scan, so usually a CAT scan of the chest, the abdomen, and the pelvis, or what can be done is a PET CT scan. So they're usually done kind of either or. We know that invasive lobular carcinomas, some of them are avid on a PET scan, some of them may not take up or show any activity on a PET scan. So what some people believe is for patients who have suspected metastatic disease from invasive lobular, a PET scan, if they're able to get it, could be attempted. We could see if that metastatic disease appears to be avid. If so, then that may be a way that we're able to sort of monitor their disease progress. Some invasive lobular cancers will not be PET avid just because they don't have that robust blood flow, and so that can certainly be a diagnostic challenge.
Dr. Ostrich, if you could comment on the liquid biopsy and the exciting next frontier.
Yeah, so liquid, so maybe I can step back a little bit. continuing on what Dr. Downs-Kelly said about loss of ecadherin. So the hallmark for lobular breast cancer is really loss of a protein what covers the lobular cancer cell, what's called ecadherin, and that provides glue from one cell to connect to the other. The reason that is lost in many ILCs is that the gene is mutated. And now the question is whether that's not only a cause of lobular cancer, but it might also provide us with an opportunity to pick up lobular cancer earlier in something what we call liquid biopsies. A lot of you have heard about liquid biopsies, basically the idea that you can take blood and you can look in blood either in floating cells, tumor cells, or pieces of tumor cells like DNA, which floats around, and maybe we can look for the presence of ecadherin mutations. And maybe doing that early on, we might detect the presence of lobular cancer before the cancer is visible on, for example, scans done by a radiologist. That is really early in development. That's only at research at the moment. I don't think there's that much done. The research which is done at the moment is it's only done in the very advanced, in the metastatic setting. And I think we have ways to go, but I really think that is something that is a potential exciting opportunity where we should study that more. I also want to comment on the unique sites of metastasis. Again, I think that might be an opportunity for us to really understand biology more. Like you just mentioned, it metastasized to these unique linings of various tissues. There seems to be a very unique attraction of lobular cancer cells to a specific cell type, which is present in linings of ovary, uterus, the eyeball, I mean the unusual places. And I think we and others try to decipher at the moment what is secreted from these cells in the lining, what might attract the lobular breast cancer cells specifically to metastasize there and then to stay there and to grow there. We don't know yet, but again, that's something where I think there's a lot of research going on, and it could be clearly a great prevention or treatment of metastasis, hopefully in the years to come.
In tandem with what you just heard, there are tools that we try to utilize that may help us identify patients who are either recurring early or give some sense of what their disease is doing, even if we know they have metastatic disease. So looking for some evidence of circulating DNA, which are components of the tumor cells, or actually the tumor cells themselves. And the only reason you get metastatic disease is because there are circulating tumor cells. And as you just heard, why lobular cancer has a tendency to go to certain places, we don't understand, but it begs the question that we know these cells are circulating. So the question about CTCs, or circulating tumor cells, was the idea that could they be used either as a way of determining the effective therapy that you're giving a patient, or could they be used as a tool to determine whether or not a patient is recurring when they otherwise clinically look like they're free of disease? And to date, there's sort of been mixed results with that. It's an interesting concept. One of the studies that was done in metastatic disease was done under the idea that, we get scans in people with advanced disease every 3 to 4 months. It's just a convention that we use. Could CTCs serve as a surrogate or an alternative to the scans and make treatment decisions earlier if you found that the CTCs were changing earlier? And in fact, that trial was done, but what it failed to demonstrate is that by knowing something a little bit earlier, meaning the CTCs changing, did you, in essence, change the outcome of patients by acting on that information earlier? And unfortunately, it didn't prove to be the case. So, I think that doesn't mean that concept is wrong. We may find that circulating or liquid biopsies may serve that purpose in the future, but right now we don't have enough evidence to say that should be the standard of care.
What do we know about something called synthetic lethality? How can that be used for treatment of invasive lobular cancer? To my knowledge, at this point in time, there's only one study out, and maybe I just want to explain this a little bit. Synthetic lethality refers to the fact that if a cell loses one gene, and in the case of lobular breast cancer, this is ecadherin, the cell is happy and grows and divides and actually moves even to other organs in the body. However, if the cell loses a second gene, the cell dies. That's what's called synthetic lethality. So we always try to figure out whether there are genes, when we lose both, is that an opportunity for treatment? The best example at the moment in cancer therapy is actually loss of BRCA1 and PARP. So the idea here is, can we find a gene, if we target it in the absence of ecadherin, the cells die. There's a group who did a screen like this. The group is in England, in London, and they found that when you lose ecadherin and you also lose a gene called ROS1, the cells die. So as a great basic research, it was done in the lab, and that study was actually then moved forward into the clinic, into a clinical trial that's going on at the moment, and the idea being that maybe in the setting of ILC, if you target ROS1, there is enhanced response to this specific treatment. This is the first time that there is the idea of synthetic lethality in ILC. Again, this is very early, but potentially promising.
Right. So the next question is about optimal treatment duration. Is it 5, or is it 7, or 10 years? Dr. Cruz, if you could answer that.
Sure. So I think this is a great question, one we struggle with for not only our patients with invasive lobular carcinoma, but for also those patients with invasive ductal carcinoma that is hormone sensitive. And if we take a step back, one of the things that many of you know in this room, but we should probably acknowledge, is that most invasive lobular carcinomas are very strongly hormone sensitive or positive for the estrogen receptor and progesterone receptor. So we take advantage of that property and give anti-hormonal or anti-estrogen type treatments after surgery to try to kill off some of these micrometastatic cells that you've heard about and prevent recurrences elsewhere in the body. Our convention for many years was to give the therapy for 5 years, and more recent series of studies have looked at extending that duration out to 10 years, mainly because as we observe the history of what these cancers do over time for our patients, many hormone-sensitive cancers tend to recur later in life. So you'll hear people talk about the risk of recurrence at 1 year, 2 years, 5 years. And really, these hormone-sensitive cancers do have unique properties that they can recur between 5 and 10 years after a diagnosis, when we hope that patients are in the clear. So as a result, we're thinking it makes sense to extend this anti-estrogen therapy longer term, and maybe we'll kill off more cells or keep them dormant during this period of time. And the studies have had some shared features, but also some mixed results that leave us a little bit puzzled as to figure out who are the best candidates to get longer term therapy. So I would say that the standard for ILC really is up in the air. We know that 5 years is our conventional standard. We can go out to 10, particularly for patients who have remaining intact breast tissue. You know, those who have not had both breasts removed. There's likely some additional benefit there in preventing new cancers. But in terms of what is optimal for ILC, I don't think any of our present published studies really answer that question directly. And hopefully we can start looking at the population in those studies and figure out who had ductal cancer, who had lobular cancer, and get a sense of the answer.
The stage of disease and treatment or mastectomy?
So the question is stage of, at the time of diagnosis and mastectomy, and influence the duration of treatment.
I think to some degree it does, and that's not necessarily something that's unique to ILC patients, but all breast cancer patients, hormone-sensitive breast cancer patients, in the sense that those who have a larger volume of disease, as Dr. Gradishar brought up, those are the ones we worry about having the higher chance of metastatic risk over time. And we do have large studies that combine the results of multiple smaller studies showing that extended benefit really for those patients with lymph node positive disease, those with more lymph nodes involved, are the ones who likely have greater benefit of the extended therapy. So I think we take into account not only disease biology in terms of ductal versus lobular, but also extent of disease when you first present. I don't know that the choice of lumpectomy or mastectomy makes a huge impact on it, but in terms of the outcomes of the original cancer you're diagnosed with. But certainly that thought of preventing a new breast cancer if you have any remaining breast tissue is highly impacted by what surgery a patient chooses.
Dr. Gradisha, you want to comment on that? And then, and some of the new stuff coming out in addition to the endocrine treatment we have.
Right, so just to amplify Megan's thoughts, I agree completely with what she said about duration. You know, corollary of that is we now are starting to see the introduction of tools that help us determine possibly who the patients are that need that longer duration of therapy. And this gets back to, you know, sort of the notion of precision medicine using molecular assays to look at tumor tissue and help define that patient who may have an ongoing risk or not, and where we might make a decision to continue therapy beyond 5 years. I know I certainly have some patients with high volume disease who are out at a decade, and I'm not particularly eager to stop things, nor are they. And even though we're in a data-free zone there, we do have patients that stay on therapy for a very long period of time. And then I think what Dr. Abraham might have been referring to is that in addition to anti-hormonal therapy alone, in the metastatic disease setting, we now have an abundance of data looking at partnering endocrine therapy with other targeted drugs, CDK4/6 inhibitors, PI3 kinase inhibitors, et cetera. And those kind of strategies are now being employed in the early stage setting to determine if that can enhance the effect of anti-hormone therapy. We don't have the data from those trials yet. Those will be reporting, but you know, I could envision in the not too distant future that adjuvant therapy will look a little bit more complicated perhaps than it does right now.
So microbiome, I mean, the $1 million question is what causes breast cancer? And so there's a lot of different things that are looking at it. So is it, you know, a genetic mutation? Well, not everybody has one that we know of. Is it a virus or is it a bacteria that maybe can cause the cells to change and turn into cancer cells? So what we've been looking at is, here at the Cleveland Clinic, is focusing on bacteria. So the microbiome is essentially the bacteria that is on our skin, in our body, that doesn't cause infection but is on us. And so everybody's microbiome is a little bit different. And so what we're looking at is that, is there a change in somebody's microbiome that would make them more opportunistic to get some type of subclinical bacteria load in their breast that might cause a cancer? And so what we've been doing with the Lerner and Dr. Eng's group is looking at collecting microbiome tissue from patients who are diagnosed with breast cancer. So if they get diagnosed with breast cancer, they provide a stool sample, a urine sample, and then when they go to surgery, a piece of their normal breast tissue and a piece of their cancer tissue gets sent to pathology and the lab. And we've been collecting data on this, and what we do know is that the microbiome is different for different types of cancer. So estrogen positive versus estrogen negative. We opened up now a HER2 positive microbiome repository. And so we're collecting the data on that, but we don't have enough information right now to say if there's, you know, anything linked to it or not. But it appears that it might be. Also looking at, you know, is there a difference in microbiome that would cause somebody to have a recurrence, have their cancer go to their lymph nodes, whereas people have the same type of cancer, the same size. Why does somebody's go to the lymph nodes? Why does somebody's not? So we're looking at that. Another interesting study that we're trying to get rolling here is, you know, what are the role of, if we think it is that, you know, what about adding probiotics, and would that help with the gut flora? So we're looking at that. We don't have the answers right now. We're collecting a lot of the data. Do you have anything to add, Erin, with that?
We've collected pretty close to 100 patients.
Yeah.
The specimens come to pathology and they're handled sterilely, and it's been busy.
Yeah. So it's nice. It's an opportunity for patients to donate their cancer and their tissue to science.
Great. So we talked about some of the standard treatment and some of the research. So Ms. Pate, from your point, what exactly is the right question? Are we asking the right question? Are we focusing on the right thing? Or are we kind of,
Well, as one of the things with the Lobular Breast Cancer Alliance and patients is that we're particularly interested in is the differences in this disease and also how we can do the research to, first of all, refine standard of care treatments to better address some of the opportunities to provide better patient care or patient care that's more tailored to lobular specific as we do the research to support that, which the other things that we are particularly interested in is looking at what opportunities now that we've started to sequence and understand some of the differences in the disease, what kinds of targeted therapies, like potentially this ROS1 therapy that was mentioned earlier might be some opportunities to go in and actually do some targeted precision medicine specifically for lobular. CTCs to try to help go around some of the consistent, the issues with imaging that can be less reliable, and often women are diagnosed at later stages. We see great opportunities to advance some of the research into refining research for these patients, and are looking forward to working with researchers to move all of that forward.
So again, we're talking about research now. So Dr. Schwarz, when one of the questions I was scanning through, lymphedema. So I know you have done some unique work on LB bypass, and so if you could comment on your work. And actually at the NCCN meeting last week, we pulled up your data and we were looking at that.
Well, that's a highly collaborative effort between the plastic surgery team and the breast surgical oncology team, because folks who have locally advanced breast cancer, lobular or invasive ductal with nodal involvement, we are trying to preserve, to the extent possible, the lymphatic drainage pathways of the upper extremity or the arm, and provide them with a safe oncologic resection. But there are certainly instances where that's not possible, because the pathways that drain both the breast tissue and the upper extremity, they collide. There's crosstalk there. So when there's crosstalk, we'll always favor removing the at-risk lymph nodal tissue. But we've devised a way to map out the lymphatic system that's draining the upper extremity. And the surgical oncology team and specifically Dr. Valente, is able to really adapt her technique in removing the lymph nodes while preserving and sort of marking the drainage pathways from the upper extremity. And if we can see those, there's some techniques that we can use that are more specialized to reestablish the flow from the upper extremity into the venous system, into the veins, which is where the lymph flow goes anyway. It just happens to go there in your neck. So it crosses through the armpit, through the axilla, and goes into the neck, and the lymph fluid dumps into the jugular vein. So if we can do some connections, and these connections happen to be particularly small and fine, on the order of a millimeter or 0.5 millimeters to a millimeter, and we can reroute as many of these channels as is possible, we think that we can sort of decrease the risk of lymphedema occurrence. And it's certainly under investigation. I think it's a promising technique, and quite frankly, from a surgical standpoint, it's all we've got right now. Our goal is not necessarily to completely eliminate the occurrence of lymphedema, because that may not be possible at this stage of the game. But if we can reduce it to the risk of developing lymphedema in folks who have just lymph node sampling procedures, like a sentinel lymph node biopsy, on the order of maybe 4 to 6% as opposed to 25%, we think that is value added. So that's where we are with that.
Yeah, so we are kind of halfway mark. So before taking the alcohol question, we can take some questions from the audience. If you could wait for a second, actually Emily's coming there with the microphone. Okay.
I just wanted you to comment on Mondor cording and how that's different from lymphedema.
How cording is different from lymphedema. It's an interesting question about cording, because I was just talking with our breast rehabilitation team about this earlier today in our cadaver lab about oncoplastic surgery. And it's unclear exactly why cording occurs. It is a very different entity than lymphedema. Lymphedema is a problem where there is a dysfunction in the lymphatic system, and lymphatic vasculature, which drains the fluid from the arm that's not in the arteries and the veins. And once there's an injury, unfortunately, it sets up a situation where you have a low-grade inflammation in the interstitial tissues, or the tissues that are outside the circulation of the arm. And so that propagates, and it causes more problems, and it's sort of a vicious cycle of fluid accumulation, and that in turn stimulates scar deposition and fat accumulation in the arm or wherever the injury occurred. And so cording is a different thing, and it's probably related to sort of tissue fibrosis, or maybe even the natural history of wound healing. So if you can think of it as a scar that kind of becomes thickened, and then over its natural course, usually after a number of months, it will soften up as the scar matures and the collagen reorganizes itself. So that's more of a self-limited thing. It's a little bit of a different scenario.
Other questions? You have a question, or? If you could wait for 1 second. Right.
Mine was very similar because there's so little to be found about cording, and it seems to be a really common minor complication. So I guess one thing I would ask of the panel, whoever it is too, maybe it's Dr. Schwarz in your area, is can we get some kind of research going about cording? Because it's an incredibly painful complication.
I think that
we should at least know what it is.
Yeah,
we don't even know what it is.
Yeah, an area that's ripe for study, for sure. Yeah.
And it seems pretty simple. It's not like finding genes or something, I mean.
I think it actually, it is genes, and I think it actually is, I think it's related to, you can put it in sort of the wound healing classification of research, which is actually a very complicated area of research. So I think the entity is simple, and luckily in a lot of folks it is self-limited and can be addressed with physical therapy, but for some it lingers. So it's certainly something that we should be looking at. Yeah.
Okay.
Yeah, I'm wondering what you think the potential for immunotherapy is for lobular breast cancer.
Okay. Good question. I was waiting for that question. Right. Dr. Gradisha, you want to start, and then we can expand?
Sure. So as probably many in the audience know, immunotherapy has been around for a while now in many different kinds of cancer, but late to the party, so to speak, was breast cancer, and we now have data that supports using immunotherapy in a specific subset of patients that have a certain type of breast cancer, certain expression of a particular marker, and there's an incremental improvement in outcome. So that's our first foray into immunotherapy, but there's a lot of work being done with a variety of different drugs. There's probably a difference, and perhaps you can comment on that, but TIL expression and other markers of immunity are different between ductal carcinomas and lobular carcinomas, and whether we can leverage that to use a strategy with checkpoint inhibitors or immunotherapy, I think is really the subject of many of the trials that are ongoing.
Yeah, I find that a fascinating question, and I think at the moment what most groups have studied, including in clinical trial, is really triple-negative breast cancer, because the thought is, and the data shows, that the infiltration of immune cells is much more in triple-negative compared to estrogen receptor positive breast cancer. Having said that, there's a very lovely study published from a European group showing that there is clearly a subset of lobular tumors which have infiltration of immune cells, and I think that sparked additional studies. There's actually a small clinical trial in Europe, it's called Gelato, where patients, I don't know why it's called Gelato.
It's Italian.
Where the treatment is an immune therapy, atezo, plus a chemo, which I don't remember at the moment what it is. Carboplatin. And so that study is ongoing, but we need a lot more. We collaborate at the moment with experts in immunology, which I always think it's great to get people with different expertises together. And we are collecting primary lobular tumors after surgery, and we look in these tumors. Okay, which immune cells are in there? Where are they located? And what subset, what percentage of ILCs have infiltration with immune cells? So I think it's really, really early. I would, go out there and say, in the end, after additional research, there might be a subset of ER positive as well, which might be potential candidates. But again, this is very, very early. But I don't think we should say that ER positive tumors are not infiltrated with immune cells. We need more research. Again, it's early, but I think it's, I think we need to do more.
It's possible to treat these tumors with some drug or sort of genetic stimulus that would cause them to become more antigenic?
I think that's, and I refer to the clinicians, I think that's what the current idea is, that maybe, upon cell death caused by radiation, chemotherapy, targeted therapy, maybe you activate the immune system, but I think I might give it over to the medical oncologists or others to comment on this.
Yeah, I would just say in a general sense that's the hypothesis, that we know radiation accomplishes that. We know that immune therapy by itself, if you give one of these drugs, they're not particularly effective, so there's synergy or more than additive when you add chemotherapy. And it may have something to do with increasing neoantigen expression on the tumor cells. But whether we can demonstrate that that translates into a better outcome, that's the subject of a lot of these trials.
Andrew, you want to comment on radiation and immune stimulation?
You can almost think of radiation like kind of stirring up the hornet's nest a bit, causing inflammation around where tumors might be, and revving the immune system up, and enhancing it further with things like immunotherapies, different immunotherapies. There's something called the abscopal effect, where you will see treatment of one tumor, and then all of a sudden other areas start to respond. And the thinking is radiation acting as an immunostimulant in a way.
So, Ms. Pate, do you mind commenting? I know, I'm sure you're looking at many of the immunotherapy stuff, and would you mind commenting on lobular breast cancer and immunotherapy field now?
We're excited to see what happens in the Gelato trial, and I think that with immunotherapy, I guess I would say that we're interested in bigger picture is when we're looking at different clinical trials and studies, is having the differences with the disease evaluated within these trials, so that we actually understand if there's a different response to the trial that's being offered. And we see a lot of times that many studies and trials don't differentiate, and so we never learn if there's a difference in how how lobular cancers, for example, might respond differently than ductal. And so as a bigger picture answer to your question, I guess what we would say is we're looking at all of these immunotherapy trials is for the ones that are appropriate and might be relevant to lobular breast cancer is to make sure we're evaluating, including lobular breast cancer and enough patients within those studies to actually understand if there's a difference that's worth pursuing for specific treatment rather than just assuming that lobular is going to respond the same to a lot of these treatments, particularly some of these novel immunotherapy and targeted therapies.
Right. Okay.
Just as a follow-up, because I'm familiar with lymphedema personally, but I've never heard of hoarding. Can someone just define it or the characteristics?
So the difference between lymphedema, what's hoarding, and how do you define? Stephanie, you want to take that question?
Yeah, so usually this happens after a sentinel lymph node procedure or an axillary lymph node dissection. If the patient puts her arm out like this, almost kind of like my shirt, you'll actually see a line that comes down here. And so they say, I'm not sure what this is, it hurts. And it kind of comes like this. And so you can call it an axillary web, or you can call it a cord. Sometimes you can feel it go down the arm here. And so the arm will be sore. And we don't know what causes it because, you can do the same surgery in 10 different women and only one gets it. So the treatment for it is we send patients to occupational therapy or physical therapy, which we call breast rehab, and it's massage. Ibuprofen helps a lot. So a lot of it is just we say, kind of take your hands and kind of go under here and massage, which you say, oh my gosh, it hurts so bad. But essentially, over time, most of them do get better. So we don't know what causes it, but we know that therapy and stretching does help it get better. And so as Dr. Schwarz said, we think it's some type of abnormal scar tissue that's not harmful, but that develops for some reason. Any comments on that?
We have a question
So
here.
I have two questions. The first is, if you have hoarding, does that increase your risk of lymphedema?
No.
Second question may be been asked before. If you don't have evidence of metastatic disease, is there benefit for screening scans of any type or blood tests of any type?
Okay. Good question. That's one of the questions we hear every day in the clinic. Megan, you want to start?
Sure. So I think it is a common question we get all the time, and it actually led to trials looking at that in the past of whether patients who had presumably curative intent treatment, where we had no evidence of metastatic disease from the very beginning based on symptoms, if there was any benefit in doing screening whole body scans or blood work to look at that earlier. And ultimately, that work showed that we can potentially detect metastatic disease in somewhere else in the body a few months earlier than it would ordinarily show up with clinical symptoms, but that starting treatment earlier for that detection didn't change the overall lifespan of the patient or outcome of the disease. So going back to what some of the other panelists have said, a lot of what we do in thinking about the CTCs, we can find them, we can do the scans, we can use them, but does it ultimately mean something meaningful for our patients? And in that particular situation, it didn't. And I think especially knowing what some of the imaging issues are with invasive lobular cancer, doing those scans may not provide us a whole lot of information.
All right, okay. We have one question from that corner. Yeah.
What do we know about pleomorphic lobular carcinoma, and does it have any implications for treatment decisions?
Okay. Dr. Downs-Kelly.
I can talk about what it looks like under the microscope to a certain degree. So classic invasive lobular carcinoma is low grade. So there are small, round, monomorphic looking nuclei. Pleomorphic lobular carcinoma is a much higher grade lesion. So these nuclei are like 3 to 4 times the size of a stromal lymphocyte. It looks very different than traditional invasive classic lobular. It's different at a molecular level too. So we always think that invasive lobulars are predominantly ER positive tumors. if we have a lobular cancer that's going to be ER negative, it's probably going to be a pleomorphic lobular. They also can be different in their HER2 status. So, you know, again, most kind of classic invasive lobulars are HER2 negative. There's definitely a subset of pleomorphic lobulars that are HER2 amplified or HER2 positive. And they also have other amplifications that we see typically more in kind of higher grade ductal lesions. But they still have the hallmark mutation in ECadherin. They will still have a loss of expression of ECadherin. And then treatment-wise?
Bill, you want to comment on that?
Sure. I mean, there have been some big, I don't know if you want to call them trials, more registries where these patients are collected and they look at the characteristics. And as was already stated, under the microscope, they look different, molecularly different. It appears that oftentimes from a clinical standpoint, they are higher stage when they're diagnosed, more nodal involvement, older age. And if you just said a blanket statement, do they do worse than conventional lobular carcinoma? The answer is yes. But if you control for all those other features, higher grade, you know, more volume of disease, the disease-specific outcome looks not so different. And with respect to therapy, we're still driven by the markers. So if somebody's strongly ER positive, endocrine therapy will be part of their treatment. If they're HER2 positive, we leverage that. So I think the markers still are what are guiding a lot of our decision-making clinically.
Maybe the only thing I can add that there was one recent sequencing study where the authors looked at various subtypes within lobular cancer, including pleomorphic. And interesting enough, they found actually enrichment of, it's a relatively small study, but still enrichment of mutations. So not just copy number variants, but actually mutations in HER2, and I think even a few HER3 mutations. So I think the idea that, like we originally thought only they are mostly ER positive, PR positive, and HER2 negative, I think for pleomorphic that's not the case. And they're not only a subset which are amplified, but there might even be single base pair, single hotspot, no, I shouldn't say hotspot, that's not right, but single mutations in HER2, which clinically might have implications.
Okay, good, very good. So then let's just talk about the next question on the list. Why can't we just start hormone treatment while we are waiting for surgery, the tests, and radiation and different things? Who wants to take that question? Megan, you want to take that?
It's a great question. Some of it, admittedly, is probably convention. Other times, I think we're getting, especially, for example, here at Cleveland Clinic, we have a multidisciplinary program where you see a breast cancer patient sees all of their relevant providers, hopefully on the first day, which includes their surgeon, radiation oncologist, plastic surgeon, genetic counselor, and medical oncologist. So many times I think we're actually decreasing that time from diagnosis to first treatment, and we want to focus on the first most important treatment at hand. Anecdotally, for patients who are going to have a long delay, whether there's a big life event or something else that they need to take care of, I think we do employ this strategy of starting the hormone therapy early. But still, for the vast majority of our invasive lobular cancer patients, surgery is still the first best option for them, in which case we'd rather focus on that, get them ready, and get them to surgery. And then hopefully we'll see them very quickly after surgery to initiate the appropriate medical therapy.
Yeah, I would just add what has already been said, that, you know, people when they're diagnosed are understandably very anxious, but with most patients who have early stage breast cancer, I wouldn't even call it a delay. You know, going through all the steps, which may take several weeks, does not change the outcome in any way if you did it in 5 days versus 3 weeks. Generally, breast cancers, for the most part, are slow growing. And the only other thing that I would add is that, you know, trying to obtain all the information necessary may afford a patient an opportunity to participate in a clinical trial. So if you sort of start some form of therapy early before you have all that information, it may make the patient ineligible, assuming they might have been interested in a trial.
So from Ms. Pate, from your side, let's just say somebody on the other side, how important is that starting something right away, or from your point?
Well, certainly when I was diagnosed, I was completely, you're in shock, and I remember getting on the phone with my diagnosing at the time, and they were like, we think we can get you an appointment with a surgeon in 10 days. And I was like, 10 days? What do you mean it takes that long? And of course now I know that this is not abnormal at all. And one of the things that, and once you learn more about the disease, you do understand that it is slower growing and not an immediate crisis. But one thing that I do think is there are two, and there's only 2 clinical trials for ILC right now in the United States, and they are both for pre-surgical trials. One is looking at different endocrine therapies before the surgery to evaluate the tumor before and after the surgery, and this evaluates the response to the therapy, but also the changes in the therapy to get a better idea of how endocrine therapy might affect lobular tumors different. And the other, it's called the PELOPS trial, and it's a trial that's been enriched. And both of those trials are very important trials done pre-surgically, and it's safe to do those and participate in those trials as a newly diagnosed patient. And many patients do need a lot of information, I think, before they feel comfortable with those 2 opportunities. So.
Good, very good. So we'll take the next question. Is any amount of alcohol okay to drink once diagnosed with lobular cancer? Who can or who wants to answer that question?
What was it, the alcohol question?
Yeah. That's right.
Oh, well, I'll weigh in.
I was trying to avoid that question for a long time.
Yeah,
it's still coming up.
That is a very common question we all encounter too, that along with dietary manipulation, et cetera. So I'm not a person who would say that you have to be so rigid that you can't have a life, number one. I say moderation with respect to alcohol. Epidemiology studies suggest that you shouldn't go swimming in alcohol. It's probably not good for you. But I don't say that you have to, people say, well, how many glasses or this or that? Then you start getting into what's the size of your vessel that you're, if it's a bucket, maybe, 1 is too many. But I wouldn't be so rigid to say that it has to be nothing. I think people can show moderation, enjoy life.
To be more specific, 1 or 2 glasses of wine a week, is that okay?
Yeah. In my view, that's fine.
Okay.
But I may not have a shared view by everybody on the panel.
I think studies show that a glass of wine a night is okay. I wouldn't go crazy and do more than that, but I think studies show that's pretty safe.
Right, okay, good. Okay, well, if we can get the microphone. So the question is, if there is liver involvement, then how do we address that? How do we handle that?
Megan will answer that.
Megan will answer that.
Well, I think that, again, this goes back to the importance of just having that one-on-one conversation and confidence in your oncologist to say, I've got something coming up, or I enjoy a glass of wine a night and it's part of my quality of life, right? Everything that we are trying to do as providers is maintain a patient's goals and a patient's quality of life, particularly when you have metastatic disease that would be in the liver, as you suggested. So there's a lot that goes into that, the volume of disease, what other kinds of treatments are you on, what are your other medical problems. But to say that a patient who has a liver metastasis cannot have a glass of wine on an anniversary or on a birthday, in my view, would be too restrictive. But I think it's important that you feel comfortable enough with your providers to ask those kind of questions.
All right, okay, so then we can go to the next question. Is there a difference in prognosis for premenopausal versus postmenopausal? So probably let's just start with a different specialty and then make sure, is it treated differently? So if you could comment on that diagnosis, the screening, is it different for premenopausal breast density versus less dense breast. If you could comment on that, yeah.
Sure. So from a screening standpoint, premenopausal versus postmenopausal, there really isn't a difference. If you're a woman who's age 40 or over, the recommendation, there is a little bit of variability, as many of you may know, in the literature and in the recent news. But what is still recommended by my association and several other major associations in the United States is annual screening mammography beginning at the age of 40, or at least for a woman to have that shared conversation with her provider. And so that is generally going to be someone who's premenopausal. Then there's a little bit of variability as well in terms of recommendations for once you get to over the age of 55. What my organization still recommends is screening mammography every year, starting at 40 and then going up to age 75, or when a woman has about 10 years of expected quality of life. So those questions are challenging. We do encourage women to have a shared discussion with their physician or their care team about the screening for those particular age groups. But from my standpoint, it would still be a screening mammogram to include tomosynthesis if that is available, if the patient is able to obtain it. The question, so other modalities that may be used in terms of screening for premenopausal versus postmenopausal women, breast MRI, which we really haven't talked a whole lot in this session tonight about screening and high-risk screening with breast MRI. But what the American College of Radiology does recommend for women who are at increased risk of breast cancer, this is premenopausal or postmenopausal, but women who have a greater than 20% lifetime risk of breast cancer. This includes people who have a history of any kind of atypical breast biopsy. Of course, the BRCA1 or BRCA2 genetic carriers who are at greatest risk of breast cancer, those are specific patients who would qualify or would be recommended to possibly have a screening breast MRI. Also included in that, and what's being more kind of widely discussed in the literature, is the issue of people who have dense breast tissue. This could be more in the premenopausal, but not necessarily only in the premenopausal age group. But what is also recommended is that that possibly be incorporated for women who have dense breast tissue. And then that would include, so not all women with a previous diagnosis of breast cancer, either invasive ductal or invasive lobular. And it's certainly not one size fits all, but I think it's certainly a discussion that needs to be had with the primary care physician, the oncologist, whoever is monitoring the patient, about what supplemental screening, specifically breast MRI, might be helpful.
And it's kind of related to that question, younger patients tend to go for more bilateral mastectomy, and of course with lobular breast cancer, now that's a major discussion you have with patients. So Stephanie, if you could comment on that, and Graham, if you could comment on the reconstruction aspect of
yeah, so we're switching to young women with breast cancer?
So premenopausal versus postmenopausal, how the treatment is different.
Yeah, so it kind of goes back to, okay, the average age for breast cancer is somewhere between 64 and 68. So if you're getting breast cancer at a young age, if we're under the age of 40 specifically, and there's no genetic component as to why you're getting breast cancer young, you know, our goal is to make you live to be, you know, as long as you want, 90 years old. And so the risk of recurrence, we don't know what causes it. And so sometimes, you know, it's caught at a larger stage, so they might need a mastectomy. And if they need a mastectomy because they're not thinking that they're going to get breast cancer when they're 30, that a lot of times we look at, number one, symmetry. So if you're getting, you know, either to be flat or with some type of reconstruction, looking at the other breast to match would be a reason that somebody chooses a bilateral mastectomy. The other one is screening. So as some of these things have mentioned, you know, it catches you off guard, there's no lump, something happens, and you've got a large cancer. You know, getting an MRI every year to screen that other breast is costly. And it's a lot of work. So you say, okay, if you got breast cancer when you're 34 and you have to get an MRI every year, you know, that's a long time to get an MRI. So again, sometimes people will choose a prophylactic risk-reducing mastectomy. And I never tell people no. I just ask people why they choose to remove their other breast. And we kind of have a conversation because it's a healthy breast at that point in time. It may never develop breast cancer. And so understanding why somebody would choose that and make sure that they have the right education and materials to make that decision, and then moving forward. And again, the good thing is that we do these advanced techniques where you have a hidden scar, nipple-sparing mastectomy. These patients look good, and the reconstruction that goes on, I mean, you wake up, your breasts look the same, they're just filled with something else. Obviously, they feel different. But I think a lot of the work that we do in plastic surgery, more women say, you know, this came as a surprise, I don't need any more surprises. And so they are opting for that. And again, it's a patient choice. So we just kind of listen to what the patient wants and make a plan that works with them. Do you have anything to add, Graham?
No, I mean, I couldn't agree more with what you said. I mean, the key is really to, I think, establish, you know, what somebody's goals are. And I think you really need to do that in the context of their prior, you know, their medical problems and their prior surgical history, and you know, really sort of help folks understand what a realistic outcome could be. And as it relates specifically to somebody who's choosing a contralateral prophylactic mastectomy, I think that I still have a conversation with somebody about this as well, because while I think we can do reconstruction well and perhaps better than ever, it still comes at a cost. You know, we're not, you know, when you choose a mastectomy, you are losing sensation to the breast, and you know, we're coming up with techniques to minimize the sensory loss or maybe reestablish some of that, but it's not right. We're not there where we can reestablish the breast as it was. There are complications that can be associated with breast reconstruction, and they can impact women's quality of life. And so I think it's important to have a thorough and well-reasoned conversation with somebody, establish goals, you know, sort of counsel regarding expectations. And if somebody is simply choosing a mastectomy, and this is very, very rare for something like, you know, symmetry, but still it's not really, it's really not for peace of mind and risk reduction, then maybe that's not the right decision. But if it's for peace of mind and a high risk, then by all means, you should have the information that you need to make a good decision.
So Andrew, in lumpectomy versus mastectomy, how the radiation conversation comes in the picture?
So for young patients?
Young patients, or that's right.
Well, so radiation after mastectomy, there's definitely, you know, a lot of changing going on. There's clinical trials that are looking at patients who, for instance, have neoadjuvant chemotherapy, and if their lymph nodes have cleared, if they were node positive up front, actually randomizing them to not get radiation. And then there's an Alliance study that's open nationally, A221-505, which is looking at different dosing of radiation, also trying to mitigate some of the side effects. So we're always not looking to radiate patients, but we're looking to minimize recurrences. So younger patients, you know, theoretically may have more time for recurrence. For the lumpectomy setting, you know, in that situation, and mostly in younger patients, premenopausal patients, we're usually doing whole breast radiation. And then within that domain, there is different dosing that's used, and the trend now is to use shorter courses of radiation because they've been found to be equally efficacious, including in lobular carcinomas, and also some studies showing better cosmesis. So, you know, for the lumpectomy setting and the mastectomy setting, can be a role for radiation, for sure. And so we have to look at each individual. But the cosmetics and ultimate, you know, functional outcomes is paramount. You want to do everything you can to balance that, to have good cancer outcomes, but also great quality of life.
Okay. And that particular question was about prognosis in premenopausal versus postmenopausal. So,
yeah.
yes.
If I might say, there is that question on our website, there was a paper, a poster presented at ASCO this past year, and we did it on lobular breast cancer with premenopausal women. That is again shows that indicates that it's a different disease. And so folks interested in more about that might want to go take a look at the abstract and the interview with the researcher, and it's on our lobularBreastCancer.org website.
Anybody else want to comment on that premenopausal versus postmenopausal, or Dr. Gradisher, or?
Well, I suppose that, historically and this isn't, comment's not restricted to lobular, but we've always thought that if you look at all things being equal, the clinical characteristics of a tumor in a younger versus older patient population, we've always attributed young age as a sort of a marker of more aggressive disease. And there have been many trials that have looked at that. From a clinical standpoint, what we do with that information is that, in a younger woman, we may have the possibility, depending on age and characteristics, of suppressing their ovaries as opposed to using chemotherapy, or using ovarian suppression in addition to chemotherapy if they continue to be menstruating. So it all is predicated on what the risk is in a given patient about what we do with that information. But younger versus older, there are some clinical maneuvers that may come into play, again, if we tie that to the risk the patient has going forward.
And Dr. Ostrich, is there any difference from a translational or research point of view, premenopausal versus postmenopausal?
We don't really know. I think I would say for research in general, we don't have many models to study lobular breast cancer. Research we do in the lab, we use cell lines, which were isolated from tumors. They grow on plastic dishes, and we look at response to therapy, or we take out genes, overexpress genes, and see what happens. And for lobular breast cancer, for example, there are only 2 or 3 ER-positive cell lines. So, and they were originally isolated from postmenopausal women, so we don't even have a model for premenopausal ILC in the lab where we can study this. Again, I think we need to do more research. I think one thing I want to follow up on, I thought that was quite interesting, that there are now clearly a couple of studies published showing that not in the early years after diagnosis, but after 6 or 8 years after primary diagnosis, there are more recurrences in ER-positive ILC compared to ER-positive IDC. So somewhat the disease is characterized by late recurrences. We don't understand the biology. We don't really know why that is. But that abstract used a large database. It's called SEER database, thousands and thousands of patients, and showed that does seem to be the case in the premenopausal setting as well. Again, we need to do more research. We don't know if the cells, for whatever reason, are dormant and they lay somewhere. And but hopefully with additional studies we can figure this out.
So the next 2 questions are about screening, mammogram versus ultrasound, mammogram versus MRI.
Sure. So for the first question, why it's not mandatory to use other devices in addition to mammography and ultrasound, really the main other modality that we use is contrast-enhanced breast MRI. And we've kind of alluded to that a little bit throughout the evening. Why is it not mandatory? There really is not a firm separate guideline for the use of breast MRI in breast cancer in general, but also specifically for invasive lobular carcinoma. So based on experience, we know on the clinical side that because of the sneaky nature of invasive lobular cancers, because of their growth pattern, because there can be more than meets the eye on the initial imaging, breast MRI is very beneficial in these patients, especially in the preoperative workup. Here at the Cleveland Clinic, we know that from experience, and so we've incorporated breast MRI into our care path. So it's, again, on a case-by-case basis. We have the advantage that we work very closely with our clinical colleagues in oncology, breast surgery. So we really review almost all of these cases one-on-one with the surgeon before they're seeing the patient. And that allows us to look at the whole big picture. We look at the mammogram to see what does this patient's breast tissue look like. Are they a very fatty breast with an invasive lobular cancer? Are they an extremely dense breast? That's kind of one decision point that helps us to triage whether breast MRI would be helpful. What we're seeing is from our surgical colleagues, a lot of these patients who are eligible for breast MRI, who don't have a contraindication, in other words, for breast MRI, especially in cases of ILC, breast MRI is utilized in the preoperative state to give us more information. So the benefit of that is, number one, we can look at the extent of disease for the breast that we know already has the cancer cells. We can look to see how big is this area. Are there any other areas hiding inside this breast that the surgeon specifically would need to know about as they're having those initial important conversations about which surgical approach is most important? It also gives us the opportunity to look at the other breast. So is there anything hiding on the other side that we aren't able to see, as alluded to in the question, by the mammogram or the ultrasound? So it is not mandatory. Certainly from our experience and what we very commonly incorporate into our practice is use of breast MRI in these patients.
And the second part of the question is, are you worried about the tracer or the contrast?
So that's a really good question, and this is something that is really coming to light really just over the last couple of years. So to just very briefly summarize, when there was a consortium of experts that met early in 2018, it consisted of radiologists and microbiologists and chemists and so forth with expertise in breast MRI, really looking at this question of what is happening to these patients who are getting the injected gadolinium contrast through for the breast MRI, or MRI in general. So what we know about MRI, just a little brief background on gadolinium, because I know this is a big question that comes up a lot, is that it has a remarkably great safety profile. So the consortium panel that met in the early of last year, they published a big paper kind of summarizing their findings from their meeting. What they reported was there have been over 460 million doses of gadolinium contrast that have been injected around the world since about the early 1990s. What we know to be true is that there is some deposition of gadolinium in tissues, specifically in the bones, in the soft tissues, especially the skin, and in the brain. What we don't know is the effects of this. So this has been reported. It is known to be true. It is recognized in the radiology literature, and people are really looking at what are the long-term effects. Is there a toxic effect of having this gadolinium deposited in the tissues? And we really don't know. So one other point to that is that there are 9 total gadolinium agents that are approved for injection in humans. And the older ones, or there's a class called the linear subtype, are the ones that had a little bit more gadolinium deposition in the soft tissues compared to, there's a newer, more widely used now that's called the macrocyclic. And basically what that means is that the gadolinium is more tightly bound to its molecule. And so what that means is when the patient is injected with the gadolinium, a bigger percentage of that is excreted, but not all of it. And so I think it's something that we will certainly hear more about. There are no known toxic effects of having that gadolinium deposited in the tissues, but we know that it is there. And so people are really looking at, why is this happening? Are there more vulnerable populations, such as people with chronic diseases like diabetes, infants, young patients, children, and that is to be certainly forthcoming.
Could I just add to?
Yes.
So I get this question a lot. So somebody has invasive lobular cancer. We, per our protocol, do an MRI prior to surgery. If they choose a lumpectomy, then they come back and we say, okay, what's your screening regimen going to look like for survivorship? And the question is, are we going to screen with an MRI? And so I go back to radiology and we say, okay, let's figure this out. Was the cancer identified on mammogram? Could we see it on ultrasound? Are both of those, did either one of those give us the extent of disease that needed to be removed? Did MRI add anything? So if we see a 2 centimeter area on the mammogram and MRI says, yep, it looks like 2 centimeters, then they're called concordant. So we say, you know what, it was found on your mammogram and it's safe to continue screening with a mammogram. If MRI showed something different, something in the other breast, then that gave us more information than just the screening. And so then we say, you know what, in you, there would be a lot more value in adding the MRI and the risk of doing an MRI. So we work with radiology to kind of come up for a personalized screening regimen moving forward in survivorship for patients like that. So that's a question that we get that's common.
Okay, good, very good. We'll move, yes, yeah.
So if
how often we recommend the MRI?
Yeah, so if the MRI added additional information, and we're going to bring that as part of your survivorship screening. Then it's a mammogram once a year and an MRI once a year, and they alternate every 6 months.
And we will, actually, I got a question from here. Are you going to get to my question? So I really apologize. We are trying to go through the questions we have based upon the likes. So I hope we'll get to your question. Right, okay, so next question is again, we can probably divide that question into two different groups. One, what's our comment about chemo in lobular breast cancer? That's one, we can approach that. And second, we can talk about premenopausal versus postmenopausal group. So Megan, you want to start with that?
Sure. I think there is certainly a subgroup of invasive lobular cancer patients who benefit from chemotherapy. The trouble is, as we've alluded to multiple times this evening, we don't really know originally at the time of diagnosis or even after surgery how to pick those patients out most effectively. We are using genomic assays and age and other clinical risk features to try to make that decision. There's a pervasive thought, I would say, in the breast cancer community that lobular cancers don't respond very well to chemotherapy, right? But I think that's probably an overgeneralization. There are certainly lobular patients that respond to chemotherapy, and we can get benefit in that treatment, whether it's making a tumor more amenable to the surgery the patient wants, or helping to make us all feel like we've been as aggressive as we can possibly be. So I think that's a very individualized decision. There are lots of trials looking at what is the best preoperative therapy, and then again, what is the best postoperative therapy in terms of chemo, targeted agents, and endocrine therapy. But I am not personally aware of a way to figure out exactly which lobular patients are for sure going to get benefit from chemotherapy.
Could I ask a question regarding that? So the oncogene or the oncotype does not help in that decision making?
It does, so we still use it. When you look back at the studies of whether it's Oncotype DX, one of our genomic assays, or MammaPrint, another common assay that we use in clinical practice, those studies are designed specifically for generally hormone receptor positive, ERPR positive, HER2 negative breast cancers, without a lot of detail in the study about invasive lobular, invasive ductal. Various institutions have looked back at their experience with those using those tests in their lobular patients, but many of those studies are very small, somewhere between 50 and 100 patients. And what we typically find is the risk scores for those patients fall in the low and intermediate range, indicating that there's likely no additional benefit of chemotherapy. So it's a very small number of patients, usually single digits, that fall into the high-risk range with invasive lobular carcinoma. And for those patients, we absolutely, as per our national guidelines for breast cancer in general, recommend chemotherapy. But I think many of us clinically feel that there's more to the story than that, and we're just not refined enough to personalize that decision at the level we'd like to.
Right, okay. The next question is about trials or clinical trials or research. Why can't we do some kind of basket trials where shared genetic mutations are the basis for the study? So Steffi, if you could start, and then Bill, if you could.
So the idea is that over the years, with a lot of genomic information, we have learned that some tumors look very similar, although they are in very different organs of the body. An example would be triple-negative breast cancer and high-grade serous ovarian cancer. There are some parallels when you look at those, although again, they're very different parts, very different organs. So the idea would be whether lobular breast cancer has specific genetic changes which might make it similar to another tumor type, which is not breast cancer. An example could be, and this is just an example, could be gastric cancer. Subsets of gastric cancers also have EKT mutation. So whoever asked this question, I guess, refers to the idea that maybe there could be clinical trials where you combine patients where the tumor, they have similar mutations, in this case, EKT. I think that's a great idea. I would love to know what the medical oncologists think about this. Personally, I think we are quite at the beginning of understanding the genetic makeup of lobular cancer, but I don't know what people think about that.
So the best part of my job today is I don't have to answer any questions. I can just answer all, I can ask questions. So Dr. Gradisha.
So I think the concept is right. I mean, in the past, we would sort of develop clinical trials for breast cancer, for colon cancer, for lung cancer, and there was no either ability or interest to really look at the different types of disease that lie within that broader umbrella of, say, breast cancer. And now we understand, you know, there's ER positive, there's HER2 positive, there's triple negative, you know, there are all these different entities, and that's not unlike what we see in other malignancies as well. So I think where there's been a lot of activity is trying, as Steffi already said, to define molecular abnormalities. And sometimes the trials are tumor agnostic, meaning that we don't care if it's lung cancer or care if it's breast cancer, but if it has that particular molecular abnormality, let's pool those patients because there's nothing special about where the disease started. It's the molecular driver that may be important, and then look at drugs that target that particular abnormality. So these kind of trials are very different than what we were doing a generation ago or even 10 years ago. And I think the hope is that by looking at things at a molecular level, the origin of the disease or where it was first located when found may have less importance than what the molecular underpinnings are. The proof of principle will lie in showing that that is indeed the case, with showing results that improve the outcome of patients. But that's sort of the direction I think most of us are really interested in today.
Lee, you want to comment on that? Or I'm sure you're following some of the trials.
Yes, well, for lobular, you know, we feel like there are very distinct, and we're still learning about these different variations, and it does offer some really good opportunities for potential basket trials. And the other challenge that I think we run into with lobular breast cancer for trials is when you're 10 to 15% of all breast cancers, it's very hard to fill trials when you're at a single institution because you're 10 to 15% of all patients. And so, you know, part of clinical trials for lobular or any subset of a disease, or to understand that, is to try to figure out the trial structure I think that will make the most sense to move the most efficient research forward faster. And so basket trials might be a good solution for some of these specific mutations for lobular.
Okay, we are kind of coming to the last 10 minutes, so we'll see if there's any other question from the audience now. Yes.
To Dr. Dean, for anyone who's had a breast cancer diagnosis, be it lobular or anything else, or if lobular is different, please comment. What about our female offspring, young female offspring? Does that change when they should start screening?
Sure, and that's a really important question. So we certainly encourage that conversation to happen at or before age 30. So a couple of things that are important are, if you were diagnosed with breast cancer, how old were you? Were you, as the mom, were you 35 when you were diagnosed with breast cancer? Which would certainly be important as we're kind of factoring into when do we need to start really screening the daughter. Were you 55 that's one very important question, is how old were you when you were diagnosed with breast cancer? And then we encourage before the age of 30 just to have that conversation about overall risk assessment. Certainly the family history of having a mom with breast cancer is really important, and then kind of incorporating that into the big picture. What the American College of Radiology recommends is to start screening mammography for certain very high-risk patients. For example, if you were to have a mom with a breast cancer at age 40, it's probably appropriate to start screening mammography at age 30, or at least to have a baseline 10 years prior to the age when the mom was diagnosed. So it's certainly important to have that initial risk assessment. Breast MRI is also, we've talked a lot about breast MRI this evening, but breast MRI is really important, especially for those young women. Those young women are in general more likely to have that heterogeneously dense or extremely dense breast tissue. And so not before the age of 25, but for those highest risk women, especially someone who has a positive family history of a BRCA1 or 2 mutation, if the patient or the daughter herself has not been tested, we would treat her as if she were positive until she had a negative test. So we would recommend a breast MRI for the daughter by around age 25, not before age 25. So what's typically for the most high-risk patients, especially if a mother has had a really young diagnosis of breast cancer, would be a breast MRI possibly around age 25 and then yearly mammography starting at age 30. With 3D, yeah, I encourage 3D. Really the standard, I think as we're going on and as tomosynthesis or 3D mammography is coming more widely available, I really think it's becoming more and more standard of care. So while not all facilities have it at this point, I would say most of them are getting to the point where they do offer it. So for patients who have access to a 3D mammogram and are physically able to do it, it's a little bit more physically taxing on the patient for any of you who have had it. For anyone who's able to get it, I think it's certainly worthwhile.
Right, okay. I think we have one more question.
Yes, I just wondered if you have any ideas on why the treatments become ineffective?
Okay, excellent
Stop
question.
working?
What's the mechanism of resistance? Who wants to take? I think, Steffi, you want to start and then, yeah.
Sure. The quick answer is we don't know.
I figured.
I think that is, the focus of research in many laboratories, both for ductal as well as lobular cancer. We think that in many cases, it's really a result of resistance to hormonal therapy. And the reason being that, 95% or so of lobular cancers have estrogen receptor and the patients are treated with hormonal therapy. So we think that maybe there are some cells which for whatever reason become resistant to that specific hormonal therapy. Why that is, that might depend on the tumor. It's clearly not the same in all patients. In some of them, we think it's a result of activation of something we call growth factor receptor pathways. So these are molecules on the surface of the cells which can turn signals outside the cells they bring them into the cell and make them grow. Examples are, which came up earlier, HER2. There are other growth factor receptor, which are called IGF-1 receptor, FGF receptor, and there are clinical trials ongoing. For whatever reason, the cells, after being treated with hormonal therapy, activate these pathways as bypass mechanism to keep growing in the presence of therapies targeting the estrogen receptor. That's one example, and I think there are many others. There are many other genetic changes which happen while the tumor is treated with hormonal therapy. I think there's a lot of research ongoing, and like I said, I think it might not be a single pathway, but it might really differ between different patients.
Anybody else want to add anything? Or? No? Okay, right. So
I'm sorry, I have one other question. Why is it, or why can it be difficult to determine whether you're estrogen positive or negative from bone biopsies?
Okay, that's a question for Dr. Downs-Kelly. Yeah.
Some of that can be due to the fact that it was actually a bone biopsy and how we have to process the tissue. So bone is very dense and it's difficult to actually cut. So when we receive a biopsy, it has to actually be fixed in different fixatives. Ideally, we want it to go in formalin. That's what all of our tissues should be going in so that we can reliably do our marker testing. But if it's a bone biopsy, it actually has to go into something called decalcification solution. And that decalcification solution can really beat up the cells, so it can beat up the antigenicity of the cells. So marker testing in something that's been decalcified is not as reliable as marker testing in 10% nutribuffered formalin, and that's why we have difficulty with it.
I would say from a clinical standpoint, though, if we encountered a patient who had if we encountered a patient who had largely bone-only disease, despite maybe being ER negative based on a bone biopsy, we may still be inclined to treat with endocrine therapy, just because that's the pattern that we typically see, not universally, but typically see with hormone-sensitive breast cancer. So we take that into account, that it may be sort of a false negative.
So, after mastectomy, what are the highest risk factors for lymphedema that can be predicted, and what can you do to prevent it?
So mastectomy by itself doesn't increase the risk of lymphedema. This axillary lymph node dissection does. So sentinel lymph node biopsy is just removing a few of the lymph nodes, and the risk for lymphedema quoted in the literature is between 2 and 5% lifetime risk. Axillary lymph node dissection is anatomically below the vein on this side, the axillary vein, between two motor nerves. So we remove level 1 and level 2 lymph nodes. There are also crossover lymph nodes, as Dr. Schwarz had mentioned, which are also the lymph nodes that drain the arm. So literature quotes anywhere from 15 to 20% lifetime risk of lymphedema. The risk of lymphedema is the highest in the first 3 years. Adding radiation on to somebody who's had an axillary lymph node dissection can increase the risk of lymphedema upwards of an additional 10%. So you're looking at about a 10% risk of lymphedema with just the axillary lymph node procedure.
But after the surgery, like I've been told mosquito bites, flying in airplanes.
Oh, what causes it?
Yeah.
Oh, so radiation is probably one of the biggest things. What we tell patients to do, so the morning of surgery, they'll have their IV put on the other side. And it's not that the IV, I've had patients from the ER, they've got a pneumonia and they can't put the IV in the arm, and they need, life-saving treatment, and they can't put it in their arm because it doesn't work. So it does work, your arm works, it works great. We just say, if you go give blood or somebody's gonna check your blood pressure, just use the other arm. They don't care what arm you give them. Sometimes the veins don't work that well, so the reality is that if you put an IV in, and it infiltrates or it gets infected, again, your arm, in order to improve that infection, these lymph nodes are helpful. Now you have lymph nodes that go up to your neck, so just because you don't have these doesn't mean that your arm doesn't work. It might take a little bit longer, and that process of infection, I had a patient who a dog bit her after, so we just put her on antibiotics, but anything that could increase your risk of getting an infection in that arm, we want to mitigate. So, some people, if they wear a heavy purse on that arm or something, we say, can you try and use the other arm? One of the big things is that people don't think about is a flu shot. So getting your flu shot in your arm that hasn't had your axillary lymph node dissection, or if you've had something on both sides, using a thigh or something like that, and it's just preventative. Just because you have your blood drawn in that arm doesn't necessarily mean that you're going to get lymphedema in that arm.
This is sort of off the subject, but I saw somebody ask on there about breastfeeding and if it had anything to do with cancer. And I asked my oncologist, and he said no. But I really wonder, because my cancer was really big, and it was in my right breast. I had a total mastectomy and 16 lymph nodes removed. My son was 9 months old, and my milk was blue tinged when I gave it to daycare. So they told me they didn't use it because of the color. So when I went to my doctor, my breasts were abscessed, and I had to have them incised and drained. So now I end up 30-some years later with breast cancer in my lobular glands. So does it have any correlation?
Right. Stephanie, you want to comment on that?
It's hard, it's hard. Everybody's different. The studies look and say, okay, if you breastfeed, it decreases your risk of getting breast cancer. Do we have women who breastfed all 9 kids for a year each and get breast cancer? Yes. So just because you breastfeed doesn't mean that you're going to get or not get breast cancer. The blue tinge in the milk could be cysts. In the operating room, sometimes when we come across a cyst, it can be a blue color. So you might have had a cyst that was connected to the milk duct that was draining with the milk. that could have been the cause for that. But as far as, 30 years later looking back, it could, we don't really know those answers.
I know we have so many really interesting questions like lifestyle and diet and all those things, but it's 7:59. So I'm going to give, Lee, if you could make the last comment from the panel about the event or any pressing questions or comments, and then we will conclude the session.
Well, so first, thanks to you and the Cleveland Clinic for everyone here for being on this and answering all of these questions. And thanks to everybody who has dialed in online and is participating in the webcast. This is a resource that is very appreciated within the patient community. I guess the main message that we would leave you with is that lobular breast cancer, there are many opportunities now that we understand, that are beginning to understand some of the differences in the disease and at the molecular level. And we are understanding that it may respond differently to commonly applied treatments. And we are very interested and excited to move forward with some of the research to understand how to refine these treatments specifically for outcomes for lobular patients, and to better understand how this disease works, why it spreads where it does, so that we can really move forward with targeted therapies. And if you're interested, the other thing we advise patients who reach out to us with questions is to use our website. The materials on that website have been researched and gone through by our scientific advisory board, and we encourage you to look at that, download material, and take it to your doctor, and sit down with your doctor and ask them all those good, hard questions that you want to know about your disease, and make sure that the treatment that's being offered to you reflects what you're comfortable with moving forward for your disease, and understand why that's being proposed for you. And otherwise, thanks everyone for being here.
I want to thank all the panel members, and again, on behalf of Cleveland Clinic and the researchers, our promise is that this is not the end of the journey. We'll continue to work on lobular cancer. We clearly understand it's a different or unique entity, and we clearly understand our limitation in understanding the pathogenesis, how the cancer happens, what treatments can be done in the future. So we'll continue to work on it. Thank Pfizer for your support. Thank you, and have a wonderful evening.